Welcome. Today, we're diving into the world of anaerobic bacteriology, exploring diagnosis, laboratory procedures, and the challenges that come with it. We'll unpack the complexities of working with bacteria that thrive without oxygen and look at how labs tackle these unique conditions. Let's get started. Let's talk about the human microbiome, the vast community of microbes living right on and inside us. These tiny organisms do some heavy lifting for our health. They help regulate our immune system, repair the lining of our gut, and even assist with nutrition. Most of these microbes are anaerobic bacteria, which thrive without oxygen, and they outnumber their oxygen-using cousins by hundreds, sometimes thousands, to one. Understanding their makeup is key to grasping their role in our well-being. When we look at anaerobic bacteria, their diversity really depends on where they live in the body. The mouth, or oropharynx, hosts a dense community, mostly bacteroids, Prevotella, Fusobacterium, and Veillonella. On the skin, the numbers drop, with Propionibacterium and others taking the lead. The lower gastrointestinal tract is a powerhouse, packed with bacteroids, Clostridium, and Actinomyces. Then there's the vaginal vault, where the mix varies, but Lactobacillus and Bifidobacterium often dominate. Each site has its own unique microbial fingerprint. Let's talk about colonization resistance, the body's natural defense against harmful bacteria. When we use antimicrobials, they can reduce the diversity of beneficial anaerobes. This makes us more vulnerable to infections like Salmonella and C. difficile. Key players like Lactobacillus and bacteroids help keep opportunistic organisms in check. In a healthy gut, these normal bacteria form a protective barrier, stopping harmful pathogens from taking hold and causing disease. In places like the lower gastrointestinal tract, obligate anaerobes vastly outnumber facultative species. This huge difference, a ratio of about 1,000 to 1, highlights just how essential these anaerobes are. They're not just present, they're the dominant players, crucial for keeping the host's ecosystem balanced and supporting overall physiological health. Understanding this ratio helps us appreciate the delicate harmony in our microbiome. When we talk about infection in someone with a weakened immune system, we're looking at two key ideas: pathogenesis and vulnerability. Pathogenesis is how the infection actually develops and spreads in the body. Vulnerability is about why the immune system can't fight back as it normally would. Together, these mechanisms explain why infections can be more severe and harder to control in immunocompromised hosts. Understanding this helps us tailor treatments and prevention strategies more effectively. Let's look at how these infections actually take hold. Anaerobic bacteria release powerful enzymes, lipases, proteases, and collagenases. These enzymes break down tissue barriers and weaken the body's defenses. Usually, infections start when the normal balance of microbes on mucosal surfaces is disturbed. This disruption lets bacteria invade nearby areas that are normally sterile. So, the infection spreads by taking advantage of these openings. It's a combination of enzymatic attack and opportunity. Let's talk about the host barrier, the body's frontline defense against infection. Some bacteria, like Fusobacterium nucleatum, have special filaments that help them stick to tissues and communicate with each other. But when the mucosal lining is damaged, through trauma, surgery, or reduced blood flow, the tissue weakens. This creates the perfect low-oxygen environment where these bacteria can thrive and cause problems. Understanding this helps us see how infections take hold when our defenses are compromised. When clinicians suspect an anaerobic infection, they look for certain red flags, signs that point to trouble beneath the surface. Foul-smelling discharge or breath, for example, can be a clear clue. So can the presence of gas in tissues, something we can feel or see on imaging. Necrotic or gangrenous tissue is another warning sign. Infections near mucosal surfaces, like the mouth or gut, raise suspicion too. And if the infection doesn't respond to antibiotics targeting only aerobic bacteria, that's a big hint. Certain patients are especially vulnerable, those with a history of broad-spectrum antibiotics, chemotherapy, transplants, or blood cancers. These factors disrupt normal defenses, making anaerobic infections more likely. When it comes to specimen management, there are some best practices we need to keep front and center. Collecting samples carefully is the first step, making sure everything's labeled and handled correctly. Then, transporting them safely so nothing gets damaged or contaminated along the way. And finally, knowing when and how to reject specimens that don't meet quality standards. Each step matters because the integrity of the specimen directly impacts the results we rely on. Let's dive into these practices in more detail. Now, let's talk about the golden rule of sampling when it comes to anaerobes. These bacteria can't survive exposure to oxygen, so keeping samples anaerobic during transport is absolutely crucial. Any delays or exposure can kill the fastidious obligate anaerobes we're trying to study. The best samples come from an aspirate of pus or a tissue biopsy taken directly from the abscess. Swabs just don't cut it. They're much less effective at recovering these sensitive organisms. Speed and sample type really make all the difference here. Now, let's look at the types of specimens that are acceptable for this process. Knowing which samples work best is crucial. It ensures accuracy and reliability in our results. Whether it's blood, tissue, or another form, each specimen type has specific handling requirements. Understanding these helps us maintain quality and avoid errors. This slide sets the foundation for everything that follows, so let's keep these specimen types in mind as we move forward. A brief transitional moment here as we move between sections of the presentation. Let's continue forward to the next topic, which we'll explore in more depth. A brief transitional moment here as we move between sections of the presentation. Let's continue forward to the next topic, which we'll explore in more depth. When it comes to collecting and transporting clinical specimens, maintaining an oxygen-free environment is crucial. We often use vials and tubes with special Hungate caps. These have rubber septa that let doctors inject fluid directly without opening the tube. For tissue samples, wide-mouth tubes help insert larger biopsies onto a semi-solid agar base. To keep everything truly anaerobic, indicators confirm vial integrity, rubber stoppers block air, and the tubes contain oxygen-free gas. These are called PRAS systems, pre-reduced, anaerobically sterilized, designed specifically for safe transport. Let's talk about chemical-reducing agents in transport media. These agents, like sodium thioglycolate or L-cysteine, help mop up any leftover oxygen that could harm sensitive bacteria. In Amy's media with charcoal, the charcoal works to neutralize fatty acids and toxins that might kill delicate anaerobes during transport. Many tubes also include a visual indicator called resazurin. If it turns pink, that means oxygen has leaked in, and the sample might not be reliable anymore. It's a clever way to keep samples safe on the move. Let's talk about specimen rejection criteria, the rules that help us avoid samples that just won't give reliable results. For example, fluid sent in a syringe with the needle still attached is a no-go. Swabs not using an anaerobic transport system won't preserve the sample properly. Gastrointestinal contents and urine usually aren't accepted, unless there's a suspected fistula. Upper and lower respiratory samples are only accepted if they're protected brush specimens. And superficial skin or throat swabs are often too contaminated to be useful. These guidelines keep our cultures accurate and meaningful. Let's explore the journey from the initial inoculation to advanced diagnostics in the lab. It all starts with cultivating the sample, growing the organisms so we can study them closely. Then comes identification, where we pinpoint exactly what we're dealing with. This process is the backbone of accurate diagnosis, guiding us toward the right treatment. It's a careful, step-by-step approach that turns raw data into meaningful insight. Here's a practical tip for the lab. When working with anaerobes, they often stain very faintly with the usual safranin. To get a clearer view, many labs extend the safranin counterstain time to 2 or 3 minutes. Another option is using a 0.1% basic fuchsin, which helps those pale gram-negative rods, like bacteroids, really stand out. The initial gram stain is crucial. It helps detect fastidious organisms that might not grow, guides which media to use, and reveals if there's a mix of bacteria. It gives us a clear snapshot of the infection site, which is key for interpreting cultures. A brief transitional moment here as we move between sections of the presentation. Let's continue forward to the next topic, which we'll explore in more depth. A brief transitional moment here as we move between sections of the presentation. Let's continue forward to the next topic, which we'll explore in more depth. A brief transitional moment here as we move between sections of the presentation. Let's continue forward to the next topic, which we'll explore in more depth. This table breaks down some key bacteria by their gram reaction, shape, and unique visual features. We see Bacteroides fragiles, which stains negative and looks like variable-shaped rods with rounded ends. Fusobacterium nucleatum is also gram-negative, but appears as long, slender rods with pointed tips. On the positive side, Clostridium perfringens shows up as large, blunt-ended rods, often called boxcar-shaped. Fingoldia magna is a positive coccus, usually in pairs or clusters. Finally, Actinomyces species are branching rods that can form distinctive sulfur granules in pus. These clues help us identify each pathogen under the microscope. Here, we see a gram stain from a culture of Actinomyces israeli. The image highlights the sulfur granules, where the filamentous structures of the bacteria are clearly visible. These thread-like formations, pointed out by the arrows, are characteristic of Actinomyces. This staining technique helps us identify and understand the bacterial morphology, which is crucial for accurate diagnosis and treatment. Now, let's look at the media we commonly use to grow anaerobic bacteria. These specialized environments are designed to support organisms that thrive without oxygen. Each medium creates the right conditions, whether it's the nutrients, pH, or reducing agents, to help these microbes flourish. Understanding the types of anaerobe media is key to successful cultivation and study in the lab. We'll explore some of the most widely used options next. Let's talk about identifying bacteroids, a group of bacteria that are really important in clinical settings. We use a special medium called blood bilesculin agar, or BBEA for short. On this agar, Bacteroides fragiles group members show up as distinct black colonies. That black color comes from esculin hydrolysis, a chemical reaction unique to them. Plus, these bacteria resist bile, which helps us pick them out quickly and accurately. This selective property speeds up their identification in the lab. Now, let's talk about anaerobic incubation. This process happens at a steady temperature, between 35 and 37 degrees Celsius, and lasts at least 48 hours before we take the first look. The chambers used here are designed to keep the environment completely free of air, allowing continuous processing without interruption. Some systems even go a step further, using gloveless setups to make handling easier and more ergonomic. It's all about creating the perfect conditions for growth, without exposure to oxygen. Let's look at how we create the perfect oxygen-free environment for growing microbes. Inside the jar, alumina pellets coated with palladium act as a catalyst. When heated, they help hydrogen react with any leftover oxygen, turning it into water. This removes oxygen completely. Some newer catalysts even work at room temperature, so heating isn't always necessary. The jar is sealed tight, air is pumped out, and hydrogen gas is introduced. An indicator inside changes color if oxygen is present, confirming the environment is truly anaerobic. This method is reliable and widely used in labs. Let's talk about the Anaxomet, a new standard for growing anaerobic and microaerophilic organisms in labs, clinics, and industry. It builds on the Mackintosh and Fildes method, but with a smart, microprocessor-controlled valve system. It automatically removes air from jars, replacing it with hydrogen gas, then uses a catalyst to scrub out any leftover oxygen. It's faster, easier to use, and takes up less space. Plus, it runs continuously for a full year without needing startup, maintenance, or cleaning. It works with both fluid and solid media, making it a real all-rounder. Let's talk about a common and straightforward way to control oxygen levels for growing bacteria, the gas pack system. It uses a sealed plastic bag paired with a special generator sachet. This sachet quickly creates the right atmosphere, whether anaerobic, microaerophilic, or rich in carbon dioxide. What's neat is that these sachets work without water or catalysts, so no hydrogen is produced. Inside, a mix of chemicals absorbs oxygen and releases carbon dioxide, tailoring the environment perfectly for different bacterial cultures. Let's talk about MALDI, TOF mass spectrometry, and its role in molecular diagnostics. This technology offers advanced identification by rapidly analyzing the unique protein fingerprints of microorganisms. It's a game changer in clinical labs, speeding up diagnosis and guiding targeted treatments. By combining precision with speed, MALDI-TOF-MS helps us pinpoint pathogens more accurately than traditional methods, making molecular diagnostics smarter and more efficient. Let's talk about the MALDI-TOF-MS revolution. This technology identifies rare species, like Egerthella lenta and unusual Clostridium, with impressive speed and accuracy. It's far superior to traditional kit-based phenotypic systems. We're talking rapid species identification, with over 90% accuracy. Matrix-assisted laser desorption ionization time-of-flight mass spectrometry is quickly replacing manual biochemical methods. It's becoming the new standard in microbial identification, faster, more reliable, and ready for the future. Let's walk through how MALDI-TOF mass spectrometry identifies bacteria. We start with a tiny sample, just a bit of a bacterial colony placed on a metal plate. Then, a drop of formic acid is added right there to break down tough cell walls, especially in tricky anaerobes like Clostridium. Next, a chemical matrix is applied to protect the proteins and help them ionize. A laser then fires, turning these proteins into charged ions. These ions race through a vacuum tube, lighter ones faster than heavier ones. Finally, the machine matches this unique ion pattern against a huge database, giving us a bacterial ID in under a minute. When the machine analyzes a sample, it gives us a numerical score. This score shows how closely the unknown sample matches the known bacteria in the database. Now, anaerobes can be tricky. Their thick cell walls block the laser light, leading to low scores below 1.7. But we don't give up. We use a clever trick called formic acid extraction. This acid breaks down the cell wall, releasing more proteins and often boosting a low score to a reliable one. That's how we get confident results, even with tough samples. Let's talk about identification accuracy, a crucial measure of any diagnostic tool. In a large study involving over 1,300 isolates, MALDI-TOF proved its strength by correctly identifying 92.5% of anaerobic bacteria right down to the species level. That's impressive. It shows why MALDI-TOF is becoming the go-to method in modern labs, offering reliable, precise results that help guide effective treatment decisions. Let's dive into molecular confirmation, a key step in identifying pathogens. Multiplex molecular tests let us detect multiple pathogens and resistance genes all at once, saving time and increasing accuracy. Syndromic panels target specific groups of microbes based on symptoms. Then, next-generation sequencing, or NGS, takes it further, analyzing complex microbial communities at high throughput. For those unusual or rare anaerobes, 16S rRNA sequencing remains the gold standard, the definitive way to identify them with confidence. Today, we're focusing on managing emerging resistance in anaerobic bacteria. These bacteria thrive without oxygen and can be tough to treat when they develop resistance. That's where antibiotic susceptibility testing comes in. It helps us figure out which drugs will still work. By testing these bacteria carefully, we can stay one step ahead, tailoring treatments to keep infections under control and prevent resistance from spreading. It's a critical part of modern medicine's fight against tough infections. Let's talk about a growing challenge, resistance in Bacteroides fragiles. Nearly all strains produce beta-lactamases, which means common antibiotics like penicillin and ampicillin just don't work anymore. This isn't just a local issue. Resistance is rising worldwide, especially in anaerobic bacteria. What's tricky is that resistance to drugs like clindamycin and metronidazole changes depending on where you are. It's a global concern that demands our attention. We perform antimicrobial susceptibility testing, or ASD, in specific clinical situations. For example, when dealing with invasive infections like brain abscesses or endocarditis, where precision matters. Also, when patients need prolonged therapy, such as with osteomyelitis, to ensure the treatment stays effective. If we isolate highly pathogenic species like Bilophila, ASD guides our approach. And importantly, when infections persist despite adequate antibiotic use, ASD helps us adjust and overcome resistance. These are the key reasons to perform ASD. When it comes to determining the minimal inhibitory concentration, or MIC, there are several methods in the lab toolkit. Agar dilution is one. It's reliable but labor-intensive, mostly reserved for reference settings. Broth microdilution is the go-to for monitoring the B. fragilis group, offering a good balance of accuracy and efficiency. Then there's gradient diffusion, like e-test strips, which are handy when you're dealing with just a few isolates. Most labs rely on commercial methods to streamline this process. Let's dive into the world of epidemiology and lab detection, focusing on anaerobic bloodstream infections. These infections are tricky because the bacteria involved thrive without oxygen, making them harder to catch. Understanding how they spread and how we identify them in the lab is crucial. It's about connecting the dots between patient symptoms, lab results, and the bigger picture of infection control. This knowledge helps us respond faster and more effectively. Bloodstream infections caused by anaerobic bacteria make up just 10 to 20% of all cases, but they're far deadlier than most. Mortality rates can soar as high as 60%. That's why rapid detection isn't just important, it's critical. When the stakes are this high, every moment counts in diagnosing and treating these infections. When we look at bloodstream infections, nearly half start as primary infections, with another third coming from gastrointestinal sources. These are the main origins we see. But it's not just where the infection begins. Underlying health conditions play a big role too. Malignancies, chronic liver disease, and diabetes are key risk factors that make patients more vulnerable to anaerobic bacteremia. Understanding these connections helps us target prevention and treatment more effectively. When it comes to blood culture protocols, timing is everything. We need to transport samples urgently within 2 hours to avoid any delay in detecting growth. Once in the lab, incubation runs for a standard 5 days in automated systems that monitor continuously. It's crucial to fill the bottles correctly, aiming for a 5 to 10-fold dilution ratio. Not too much, not too little. And remember, each set should include both an aerobic and a dedicated anaerobic bottle. This approach helps us optimize recovery and get the best results. Let's talk about toxin-mediated diseases, focusing on Clostridium difficile infection. This kind of illness happens when bacteria produce harmful toxins that disrupt our gut. Diagnosing it isn't always straightforward. We rely on algorithms, step-by-step guides that help us decide which tests to run and when. These tools make sure we catch the infection early and treat it effectively. Understanding this process is key to managing the disease and preventing complications. Pseudomembranous colitis usually starts when the balance of our gut microbiome is disrupted, often from antibiotics. This disruption allows C. difficile bacteria to overgrow and produce toxins A and B. These toxins cause inflammation, which shows up as yellowish, raised pseudomembranes during a sigmoidoscopy or colonoscopy. It's a clear signature of this infection, helping doctors identify and treat it effectively. Let's break down the 3-step algorithm we use to detect toxins A and B first. We start with GDH screening. This test is highly sensitive, so if it's negative, we can confidently rule out infection. Next, we test directly for the toxins themselves. This method is very specific, meaning a positive result confirms infection, but it can miss some cases. Finally, when results don't match, like a positive GDH but negative toxin test, we use nucleic acid amplification, or PCR, for the most accurate confirmation. When it comes to diagnosing CDI, testing for a cure after treatment isn't recommended because colonization often lingers without causing symptoms. We should avoid repeat testing within 7 days to prevent unnecessary confusion. The guidelines favor NAAT over toxin EIA when used alone, since it's more reliable. And importantly, testing should only be done on stool samples from patients who actually have clinically significant diarrhea. These are key recommendations from the IDSA to guide us. Necrotizing infections in the mouth can lead to serious clinical complications. These infections don't just affect the tissues, they can rapidly destroy them, causing severe pain and swelling. If left untreated, they may spread to deeper structures, leading to systemic issues. Understanding these complications helps us recognize the urgency in diagnosis and treatment to prevent long-term damage and improve patient outcomes. Let's explore what makes these infections so dangerous and how they impact oral health. Let's talk about necrotizing soft tissue infections, or SSDIs. One type is caused by Clostridium septicum. It's strongly linked to hidden gastrointestinal cancers, which makes it especially dangerous. Then there's spontaneous gangrene, often triggered by this bacteria. On the other hand, traumatic gas gangrene usually follows lower limb injuries and is commonly caused by Clostridium perfringens. This happens in damaged tissue where the bacteria thrive, leading to rapid tissue death. Both conditions demand urgent attention. Gastrointestinal crises are serious complications we need to watch for, especially after stem cell transplants. One is intestinal thrombotic microangiopathy, a condition that can cause dangerous perforations. Then there's pneumatosis intestinalis, where gas infiltrates the gut wall, something we often see in transplant patients. Another is neutropenic colitis, or typhlitis, marked by fever and pain in the lower right abdomen, common in leukemia cases. These acute abdominal events require quick recognition and action. Looking ahead, restoring the microbiome is a key focus for improving health in powerful new ways. At the same time, high-throughput analytics are revolutionizing how we gather and interpret data, making it faster, deeper, and more precise. Together, these future directions promise to unlock insights we couldn't access before, opening doors to personalized treatments and better outcomes. It's an exciting frontier, where biology and technology come together to reshape what's possible. Now, let's look ahead to the next frontier in treating recurrent infections. Fecal intestinal microbiota transplantation, or FMT, is emerging as a powerful form of bacteriotherapy. At the same time, rapid analysis pipelines are turning raw genetic data into actionable clinical insights faster than ever. And with next-generation sequencing, we're seeing massive leaps in speed and affordability, far beyond what Sanger sequencing could offer. Together, these advances are reshaping how we understand and treat complex infections. Fecal microbiota transplantation, or FMT, has transformed how we treat recurrent infections like C. difficile. By analyzing microbial communities, we've made this therapy both safe and highly effective. In fact, FMT now sets a new gold standard, with cure rates exceeding 90%. It's a powerful example of restorative medicine in action, using nature's own tools to heal and restore balance. This success is changing the way we think about treating infections that once seemed impossible to beat. Working with anaerobic bacteria in the lab comes with a unique set of challenges. Oxygen toxicity is a big one. Just a brief exposure can kill these sensitive microbes, leading to false negatives. Then there's the slow growth. Some anaerobes take up to 2 weeks to form colonies, which really slows down diagnosis. Infections often involve multiple species, making it tough to pinpoint the main culprit. Plus, it takes highly trained staff and costly, specialized equipment to get accurate results. On top of that, constantly changing bacterial classifications mean labs have to stay on their toes to keep data up to date. As we wrap up, here, a look at the key references and studies that informed our discussion. These sources provide the foundation for the ideas we explored today. They're a mix of research, expert insights, and data that help us understand the topic more deeply. If you want to dive further, this bibliography is a great place to start. It's the backbone of the work we've shared. Here, we've gathered the major references that form the backbone of our discussion. These key studies and guidelines cover everything from the role of intestinal microbiota in infection, to the complex nature of Bacteroides bacteria. We also include clinical practice guidelines for C. difficile infection and important protocols for detecting anaerobic bacteria. These sources provide the scientific foundation that supports the insights we've shared today. Here, we're crediting the sources for the images used throughout the presentation. Each image comes from a trusted site, helping us illustrate complex ideas with clear visuals. It's important to acknowledge these resources. They support the accuracy and credibility of what we've shared today. This slide wraps up the visual journey we've taken together. Here, we're sharing the sources for the images used throughout the presentation. These come from specialized websites focused on gastrointestinal health, microbiology, and diagnostic techniques. Citing these sources is important. It shows where the visuals originated and gives credit to the experts behind them. It also helps anyone interested in exploring the material further by pointing to reliable, authoritative resources. A brief transitional moment here as we move between sections of the presentation. Let's continue forward to the next topic, which we'll explore in more depth. This video was created with SlideSpeak. Visit SlideSpeak to turn your presentations into engaging AI-narrated videos.